Howdy everyone, my name's Corey, and today my presentation is going to be on Stair for women veterans with military sexual trauma, and this is a telehealth skills-based intervention model. On this slide, I'm introducing the intervention I focused on, which is skills training in effective and interpersonal regulation, or Stair. Stair is a manualized, skill-based treatment originally developed for people who have experienced chronic interpersonal trauma. Instead of jumping straight into trauma narratives or exposure, it focuses first on teaching emotion regulation and interpersonal skills that often get disrupted by repeated abuse or harassment. In this presentation, I'm looking specifically at how STAIR can be used with women veterans who have experienced military sexual trauma or MST and how it's delivered via telehealth in veteran affairs settings. So we're talking about an intervention that is both evidence-based and highly relevant to access issues for rural or underserved veterans. My goal is to show how STAIR functions at the program level, what the research says about its effectiveness, and why social workers and the VA staff should feel confident in considering this model when working with MST survivors. Before we can talk about STAIR, we have to ground ourselves in the problem it's addressing, the military sexual trauma, or MST. The Department of Veterans Affairs defines MST as sexual assault or threatening sexual harassment that occurs during military service, and it can happen to people of any gender, in any branch, and at any rank. MST is just not an event. It's associated with profound mental health consequences. Survivors have elevated rates of PTSD, depression, anxiety, substance use, suicidal ideation, and serious functional problems in work, family, and social roles. So the intervention I chose isn't just a generic PTSD treatment, it's responding to a specific gendered and institutional form of trauma that has deep implications for how we think about care, access, and justice for veterans. In terms of scope, MST is unfortunately common and persistent. A major meta-analysis found that about 15.7% of military personnel and veterans report MST overall, including about 3.9% of men and 38.4% of women, when both harassment and assault are measured. More recent studies in U.S. veterans show similarly high rates, with one large study estimating that about 44% of female veterans and 3 to 4% of male veterans report MST, and that MST is strongly associated with higher mental health burden and suicide risk. From the numbers in the last slide, we see that women veterans are affected most by MST. Men and gender diverse populations don't often speak up or report due to stigmas around men's mental health or the invasive hypermasculinity that is extremely present in military culture. Historically, earlier research focused on documenting that MST exists and that it's linked to PTSD. Over time, the literature has shifted towards understanding mechanisms, for example, institutional betrayal, gender discrimination, and power hierarchies in the military, as well as barriers survivors face when seeking care and benefits. For social work, this matters because MST sits at the intersection of trauma, gender systems, and policy, all core areas of our profession. Now we'll move into the components of STAIR itself. STAIR is a structured, time-limited intervention typically delivered over about 8 to 10 sessions in the MST telehealth studies. It was designed for people with chronic interpersonal trauma where the main issues aren't just intrusive memories, but also emotional storms, numbing, and relational difficulties. The core modules include emotional identification and awareness, and helping clients notice and label their emotional stress, emotion regulation and distress tolerance skills, helping them learn concrete strategies to manage intense affect. Next, understanding relationship patterns, helping them examine how trauma has shaped trust boundaries and expectations of others. Then interpersonal skills and assertiveness, and practicing ways to set limits, ask for support, and navigate conflict more safely. The key idea is that by strengthening emotion and relationship skills, MST survivors are better able to function and connect with others, and if they choose, potentially engage in trauma-focused therapies later on. For this assignment, I focused on STAIR as it's used with women veterans who have experienced MST and who screened positive for PTSD or significant trauma-related distress. The telehealth trial specifically targeted women veterans, often in rural areas, who face additional barriers to specialty care. Stair in this context is typically implemented in VA healthcare settings, for example, through MST programs, PTSD clinics, or integrated mental health services that used home-based video telehealth or clinic-to-clinic telehealth. An example set of the program goals might look something like this. Deliver 8 to 10 telehealth Stair sessions to women veterans with MST. Achieve significant reductions in PTSD and depression symptoms. Improve emotion regulation and social/interpersonal functioning. Offer a skills-focused alternative for veterans who are not ready or do not want to engage in trauma-focused exposure therapies. These goals align with both symptom reduction and the broader social work emphasis on functioning and relationships. Next, I'll summarize the evidence base for Stair with MST survivors, starting with the pilot and then a randomized controlled trial. First, a 2018 pilot telehealth study by Weiss and his colleagues delivered Stair via video teleconferencing to rural women veterans who had experienced MST. The study found that Stair was feasible, acceptable, and showed promising pre-post improvements in PTSD, depression, and emotion regulation with high satisfaction and good engagement. Building on that, a home-based telehealth randomized controlled trial by Cloitre and colleagues in 2024 compared Stair to present-centered therapy, or PCT, in 161 women veterans with MST and PTSD. Both groups improved, but Stair produced greater reductions in PTSD severity and better outcomes in social support and other mental health domains, suggesting that a skills-focused intervention can outperform a strong, active comparator. These studies helped establish Stair as a rigorous, evidence-based program, not just promising an idea. Stair is grounded in a cognitive, behavioral, and emotion regulation theories of trauma. The model assumes that chronic interpersonal trauma, like MST, disrupts a person's ability to understand, tolerate, and express emotions. It distorts relational schemas such as expectations around trust, safety, and power. By directly teaching emotion and interpersonal skills, Stair aims to repair some of these capacities and improve daily functioning. Across the research, outcomes are measured with standardized tools such as the Clinician-Administered PTSD Scale, CAPS, and the PTSD Checklist Depression Scales like PHQ-9, and measures of emotion regulation and social functioning or social support. Beyond the pilot and RCT, we also have WebStair, which is a brief peer-supported Stair programs that combine online modules with telehealth coaching. Studies of these formats have shown improvements in PTSD, depression, emotion regulation, and functioning in broader veteran samples, including those in rural areas. Taken together, the evidence base includes pilot feasibility work, randomized controlled trials, telehealth implementation, and web-based program evaluations, which is exactly the mix you'd hope for seeing in a growing program-level intervention. There are several clear strengths of Stair for MST survivors from a social work and evidence-based practice perspective. First, it's explicitly skill-focused and trauma-focused, which make it a good option for veterans who either don't want trauma exposure or are not ready to do it yet. That can be particularly important when the institutional betrayal, distrust of systems, and stigma make deep trauma work feel like unsafe. Second, Stair is effective when delivered via telehealth and web-based formats, which directly address access barriers for rural and underserved women veterans. This is a major equity issue as travel, childcare, and work schedules can all interfere with in-person specialty care. Third, the content of Stair Emotion regulation and interpersonal skills is deeply consistent with trauma informed care and with social work's focus on relationships, empowerment, and improving daily function, not just reducing symptom scores. So, Stair is both clinically meaningful and chromatically flexible, which is a powerful combination. At the same time, the literature points to important limitation and gaps. One major limitation is that most MST specific STAIR studies have focused on women veterans. We know that men and gender diverse veterans also experience MST and often face even greater stigma when seeking help, but there is much less STAIR research on these populations. Another issue is that most outcomes are measured in terms of symptoms and short to medium term functioning. We know less about longer term outcomes like employment, housing stability, re victimization, or long term relationship health for veterans who receive STAIR. In web only or brief formats, engagement can be a challenge. Some studies of web STAIR note that completion rates are higher when there's an active peer or clinician support, raising questions about how to sustain engagement at scale. Future research could expand STAIR to include a more diverse group of MST survivors, include longer follow up, and test implementation in non VA settings, which as community agencies or within DoD systems where MST is occurring. From a social work practice perspective, STAIR offers a very practical tool for clinicians working with MST survivors. At the micro level, STAIR provides social workers with a structured, evidence based intervention that remains relational and strengths oriented. It supports survivors in learning concrete skills to manage emotions, set boundaries, improve communication, and rebuild trust, all of which are critical in the aftermath of MST. Because it can be delivered via telehealth, it also fits well within integrated behavioral health and rural outreach models, where social workers may coordinate care across settings or reach veterans who don't live near a large VA medical center. STAIR's focus on skills before trauma processing also aligns with trauma informed principles like safety, choice, collaboration, and empowerment, which are central to ethical social work with survivors of military sexual violence. At the macro and policy level, STAIR connects directly to the social work values in the NASW Code of Ethics. The value of a person's dignity and worth is reflected in how STAIR centers survivors' goals for their own lives, better relationships, better emotion coping, rather than focusing only on symptom reduction. The value of human relationships is literally built into the intervention, which targets attachment, trust, and social support as key outcomes. In terms of social justice and service, MST is an example of harm occurring within powerful institutions. Social workers can use evidence on STAIR not only to provide direct care, but also to advocate for funding, training, and broader implementation of effective, trauma-informed program for MST survivors. This ties into larger policy concerns like disparities in VA disability claims for MST-related PTSD, and the need for systems that both treat and compensate survivors fairly. So STAIR is just not a clinical tool, it also is a part of a larger conversation about how our systems respond to survivors of military sexual trauma. For peers or practitioners who want to learn more, I'm highlighting 3 resources on this slide. First, I include an article by Ong and colleagues, published in 2024, that examines a brief peer-supported web STAIR program for trauma-exposed veterans. This study shows improvements in PTSD and depression, emotion regulation, and psychosocial functioning, and it demonstrates how STAIR principles can be adapted into scalable web-based formats. Second, I link to the VA National Center for PTSD's Military Sexual Trauma webpage. This site provides accessible information about what MST is, how it affects people, and what kind of treatments, including skills-based and trauma-focused options, are available through the VA. It's a useful resource for both providers and veterans. Third, for an advocacy-oriented resource, I include the report Battle for Benefits, VA Discrimination Against Survivor of Military Sexual Trauma, produced by the Service Women's Action Network and the ACLU. This report documents how MST survivors have historically faced lower approval rates for PTSD-related disability claims compared to other PTSD claims, and it calls for policy reforms and better oversight. Together, these resources connect clinical practice, ongoing research, and policy advocacy around MST.